Hi, welcome. Hello, everyone. This is Nicholas Hall, founder of Graham's Foundation, and I'm here today with Ed Bell. Ed, I want to give you a chance to introduce yourself so the community knows a little bit more about why I'm excited, curious, and interested to talk to you today.
Thanks, Nicholas. I'm happy to be here and to speak with you and your audience. Um, I'm a professor of pediatrics at the University of Iowa and a neonatologist, and I've been in practice for 46 years. So I've seen a lot of changes over time in what's possible for treatment and outcomes in premature babies. Uh, when I joined the faculty at the University of Iowa in 1979, we were feeling pretty good if we were able to save a baby of 28 weeks gestation, and now we are having some successes with babies of 21 weeks. So we've we've seen what we call the limit of viability drop by about 1 week every decade or so. With the technical advances and increased in skill and new and better equipment in our field. So this has been a tremendous privilege and a great career to be able to participate in this and see these changes over time.
I didn't realize, um, yeah, I didn't actually realize that now that you share that perspective, that it's been that's significant um, and that transformational. And I'm curious, I'm aware of surfactant and the transformational impact that that had, and as I understand it, the ability to provide life-saving oxygen to a premature baby in a way that wouldn't destroy the baby's lungs. That's my layman's understanding of how that really kind of transformed um, the the opportunity to save a baby born earlier than 28 weeks. Have there what other transformations in your experience, and maybe that was a game, maybe you'd call that a game changer. And I don't know if there have been other game changers, or if not, not necessarily, maybe some that maybe not a change, but certainly an impact, right? An impact player versus a
Yeah,
game changer. Yeah.
yeah, surfactant is clearly the best known and one of the biggest game changers. The only other one I would say that compares in terms of magnitude is the understanding of the value of steroids given to the mother in premature labor, because antenatal corticosteroids given to the mother can uh, decrease the risk of her baby dying by half uh, by speeding the rate of maturation of the lungs, but not only the lungs, but other vital organs, including the brain and the intestines and the kidneys, the skin. So if the mother gets 2 injections of steroids in the 24 hours or so before the baby's born, that has the effect of essentially increasing the baby's maturation by about a week. So it's a tremendous breakthrough. There are lots of other
Yeah.
smaller advances that uh, taken collectively have had a great benefit, but any single one is, not as important as surfactant and steroids.
Out of curiosity, I know often if a mother is showing signs of premature labor, or there's something that demonstrates maybe there's interuterine growth restriction or something like that that shows a risk. Is the steroids, is it is the timing of it such that you'll wait until it's as best you can until it's close to the delivery, or is it can it be delivered, at any time? Let's say, if the mother's water breaks at 22 weeks, but you're hoping that she can she can keep the baby inside for another few weeks. Do you provide the steroids like right away, or do you actually wait?
Well, if her water breaks, the chances are pretty good she's going to deliver. So you probably should give the steroids. That you're playing a pretty dangerous game if you try to hold off and give the steroids close to delivery,
Yeah,
because you can't predict when she's going to deliver. That's the problem. And important thing is to get the steroids in. And if it's another week or two or three until she delivers, that's great in terms of giving the baby more time to mature. Uh, the ideal time is to have the steroids within a week of delivery, and occasionally a booster dose of steroids can be given if it's longer than that.
gotcha. Now I know our twins were born in 2006, and at that time, 24 weeks was considered, um, that was kind of the date, the cutoff date of intervention. I know that, with in our situation, it was IVF. So you knew exactly, right? You actually knew exactly the weeks and the days, and there's baby A and baby B and the impacts of that. Sometimes I suppose it's not entirely sure. Mothers may not exactly aren't going to know the exact date of when they got pregnant, and I imagine the maturation, that yes, days and weeks and days tells you something, but really it's it's really seeing the baby, or it's really early, the fetus, and just how well how developed that particular baby is. I would think that is a huge indicator.
Yes, exactly. Unless you have had IVF, uh, our information on the pregnancy dates is imprecise. And the best we can do is within about 5 days or so, based on the mother's last menstrual period. Having an early ultrasound helps us to get a little better guess, but we have different hospitals have uh, different policies as to what's the earliest baby that they will resuscitate, and it's based on how many weeks. And if the limit is 24 weeks, more often nowadays it's 23 or 22 weeks, but it's not the same in every hospital. If let's say it's 23 weeks, and your wife is now 22 weeks and 6 days, and she's going to reach 23 weeks at midnight, that's a little bit of an arbitrary cut point. And if it's 11:30 p.m., she's got 30 minutes to wait. That's kind of a really arbitrary cut point. And if she was, a half hour east and was in the Eastern time zone instead of the Central time zone, she'd already be 23 weeks.
Yeah,
So it's kind of silly in a way. And as you said, some babies mature faster than others. And we know it depends not only on gestational age, but also on birth weight. We know that girls mature faster than boys. We know if the babies are twins, they may mature a little slower than if it's a single baby. We know of course, if the mother got steroids, the babies are going to mature faster. So it's rather complicated, and so we use gestational age uh, for simplicity, but it's more complicated than that.
Is there a I know that you so I'm curious the Tiniest Baby Registry. You started that back in 2000,
Right.
correct?
Yeah.
How did you gather information for I took a look at it. I mean there were like babies from
1930s.
I know. So how in the and how I guess there's really no way to truly verify that data, but how did it come in? Did the word just kind of spread throughout neonatal intensive care units around the world, or was it mostly like lived people that actually survived and self-reported? Just
Well,
curious.
yeah, let me just start by saying what the registry is. It's an online registry of babies who weighed less than 400 grams, which is about 14 ounces, that survived to go home. And I started this after we had a baby that weighed 359 grams back in 1994 that survived, and the parents said, "Are there any other babies this small that have survived?" And I said, "I know about one that was born in Chicago, and there was an article in People magazine and later in the New England Journal of Medicine, and let me see what else I can find." So I started searching in the medical journals and lay magazines and on the internet. And by 2000, when I started the registry online, I had found 15. The ones from the 1930s were published in two of them in medical journals, one in Time magazine. And so now we have 331 patients in the registry. And nowadays, most of them are submitted by the parents or the patients themselves. And I do insist on getting confirmation from one of the treating physicians to make sure that the information about birth weight is accurate. But there were those three patients from the 1930s, and then there weren't any for 50 years. And then we started having some in the 1980s. Now we have about one a month that's reported. But these are very special patients because in order to survive at that extremely low birth weight, these are all patients that were not growing very well before birth. They are small for their gestational age, and so they are different from a baby that grew normally but was just born extremely early. So they're sort of a special case.
And do they have, are you referring, is that typically the IUGR, the interuterine?
Exactly. Yep. Yep. Intrauterine growth restriction.
Does that, I'm curious, has that shown to have any particular, has there been any sort of longer term studies to see um, what, I guess, what outcomes, if any, are presented from like something because so often with premature birth it's like it's an occurrence it's not a diagnosis so
Yeah.
but that is a reason for a premature birth and it's actually impacting the development
Yeah.
of the
Yep.
baby which is unique in oftentimes usually it's
Yeah.
something with the mother yeah.
Yeah. Yeah. Those babies that are extremely growth restricted are at higher risk of having uh, neurologic delay developmental delay and neurologic problems down the road. So half or more than half will have significant problems. And of course, they'll always be small compared to their age peers. They'll be underweight. They'll be short. So that's a particularly high risk group of patients. Premature babies overall, those who are normally grown but just happen to be born early for other reasons are at some increased risk, but the risk's not nearly as high as for those that are small for gestational age.
Gotcha. What are the what are the survival rates these days for depending on what we believe to be the gestational age of the baby? I know, for us, the 25 weekers, I think it was kind of 50%, back 20 years ago, but I think it's gotten, significantly.
Yeah, it's much better now. It should be 80 or 90% in most U.S. centers. I think it's 90% at University of Iowa. 24 weeks, it's about 80%. 23 weeks, it's about 70%. 22 weeks, it's 65% at Iowa.
That to me is significant. I mean, that's, as a former numbers person, that's like significant. That's transformative.
Yeah.
Is there anything, and maybe it's the collection of a lot of different treatments, but um, just curious, in your opinion, how has the survival rate improved so dramatically in just in this last 20-25 years?
Um, well, let me say that the figures I just gave you are for Iowa. They're not that high everywhere, but uh, we are probably we have our rates are among the best in the country, really in the world. But there are a number of other centers that have rates this good. A few in the U.S., several in Sweden, several in Germany, and quite a few in Japan. And what all of these centers with high survival rates have in common is the belief that these babies should survive and have good outcomes. I mean, there are things that we do the same, but there are also things technically that we do differently. But the most important underlying feature is the culture and the belief, starting with the obstetricians and carrying through to the neonatologists, the nurses, the respiratory therapists, everyone that works in the unit has seen these babies survive and do well, and so have come to believe that that's possible, and in fact, come to expect it.
Well, I think and having attended some conferences where your peers are presenting, obviously not nearly as many as you have, but I've heard from your peers at locations like yours where they have they've defined a program. They've called, they have a name, and they have an approach, and it's a
Yeah,
methodology. And I think when you're willing to have that, then you've got something to measure yourself against. You've got a filter to look through. How are we doing things today? And are there things that we can continue to be looking at? I am, I'm curious. So, um, there certainly are stories of of um, babies being born prematurely, and it happens at home, or it's a complete surprise, and there is no time. So then there isn't the time for the steroids. I mean, even regardless, there isn't time for any of that. But there are plenty of instances where there's there's signs. It's high risk. Um, they're becoming preeclamptic. There's an awareness. Um, I know in our experience, we had weeks, but we didn't know anything about prematurity. We didn't still didn't know anything about a neonatal intensive care unit. Um, I'm sort of like surprised, but not surprised that if you have some amount of time and you see that there's some risk, it's like, why would you not want to be able to pick and find the best place for your baby to be born, knowing that there's a high likelihood of what the course is going to look like. We kind of do that if we have cancer and we have some time. We sort of we look around the market trying to figure out where the best, for our particular situation.
Yeah, it's
But
easier if yeah,
yeah,
it's easier if you have cancer. Pregnancy is a little different and things happen unexpectedly, but if you do have the time, I think social media is helping uh, pregnant parents understand that there may be some places that are better than others, uh, and organizations like yours are helping to inform the public. But I think many people have no idea that
yeah,
there are uh, that the care is not uniform, and that the approach to care is not uniform, and that there may be two very well-known hospitals in the same city where one will actively provide care for a 22-week baby, whereas one down the street will not offer care, but will consider that baby to be what's called pre-viable, or too early to have a chance. And there is a parent group called 22 Matters that has a Facebook page and uh, a Twitter account that has a map that shows hospitals all around the world that have had successful outcomes for babies at 22 weeks. And in some cases gives details about how many and how long they've been treating babies at 22 weeks. And they have stories from parents. We have parents all the time that come to our hospital to deliver after being told at the first place they went that there was nothing that could be done, and if the baby was born, they could hold it and watch it die. And then somebody tells them through social media that there is a place not too far away where they could come and the baby would be given a chance. We've had people come from other states even to come and wait until their baby was born. But it's not easy to do.
yeah,
And I've pondered this issue. Uh, I don't think we necessarily want every hospital to try to be providing care for these very fragile babies. I think that ideally you should have centers of excellence like you do for treating certain cancers or doing heart transplants or other care. But then you have the issue of the woman who suddenly goes into labor. So you need every hospital to have some idea how to provide this care and then transfer the babies. But babies that are born in one hospital and transferred to another don't do quite as well. So it's a sticky issue.
yeah. It is. Yeah, it is. And yeah, I I know I grew up with a heart condition, and my parents, you know, eventually, fortunately, eventually the pediatrician in our decent sized city in Ohio said this is too complex for us. We need to,
Yep.
we need to work with you to find uh, another solution.
Yeah, good for him. In Germany, the results of premature baby care are in each hospital are public information. So you can look up, what your nearest hospital's results are for babies of certain gestational ages, and if you don't like them, you can find another hospital.
I mean, it makes, I mean, the numbers of level 3 and level 4, NICUs, the number of them across the US, I mean, it's a significant number. And um, again, I know there were a few times when I was having an episode with my heart and I show up in an emergency room in, you know, rural America, and they're just like, what's this? I'm like,
Yeah,
it's like, well, isn't this an interesting case? That's not what yes, someone has to be that, someone has to break new ground, but you don't want to be doing it all over the place all the time. Um, that's why you like people that have learned the culture and the program at your facility and then go to another facility and be able to bring that culture, that knowledge, that mindset to another institution.
yeah,
Yeah, I learned early on when I was just trying to, with Graham's Foundation, we were just trying to provide um, the resources and support to parents. And at the time we were living in California, and I was just visiting the different neonatal intensive care units in my region in California. And I quickly realized as a business person that it doesn't matter if they're all in the Kaiser system or they're all in the, if it's University of Iowa or IU, they're all their own separate unit. They're not, they may share and they may, collaborate to some extent, but they're also uh, running their own shop as well. Um,
yeah,
what are the things? Yeah, go ahead.
yeah. I like the things that your group does with providing mentors for families. That's something that we started doing here in the 90s, uh, and it was very successful. We had a I started doing that just on my own in the late 80s or mid 80s, and then we got a formal parent support group called the Parent Connection going in the early 90s, when I was the medical director and our social worker and nurse manager. We got that going, and uh, it was a really good thing to do. When I started as medical director in 1988, I think our unit was like most units at the time. It was not parent friendly at all. Uh, we had visiting hours for parents.
Right.
Parents were only allowed to visit for a few hours in the afternoon. They were not allowed in during rounds. They were escorted out when an X-ray was being taken in the unit. We didn't even have a waiting room, so they would be sitting on the floor in the hallway outside the unit waiting for visiting hours to start. It was really horrible, and so we started by building a waiting room and opening up the unit, except during rounds. It took me another decade to get all of my colleagues to agree to let parents stay during rounds. They were worried about issues of confidentiality and embarrassing trainees uh, during rounds because all the patients at that time were in one room. Now we have single patient rooms, but they were afraid that if the parents saw uh, how little that the residents and fellows knew on rounds that they would it would undermine their confidence, and it took another 10 years or so before we could get parents to stay during rounds all the time. So now we have, since 2004, we have a single patient room. So every baby has his own room, so the parents can stay all the time. They can sleep in their room if they want to, and it's much better.
Yeah, I mean, you're touching on an area in terms of just parent support, the the environment. Um, that that's definitely not the same everywhere for sure. And I understand that not every facility has the same resources, um, and that with parent support, there is no box you can check to bill Medicaid or insurance for parent support. So that's kind of it's above and beyond. And you know, we were in the NICU again, 2006. No family lounge, no lockers, no absolutely nothing. Big open bay. Didn't know we could attend rounds until we were, you know, well after my son had passed. So, a few months in, and realized like we were there so much, we were learning, we were understanding, we could really contribute to the conversation, to the care for our daughter. And the only mentor experience we had was just informally talking to a mother who had to discontinue support for one of their twins as well. And so it was just a nurse that happened to know what we were about to go through with our son, who happened to call a mother who happened to be willing to come in and talk to us. And that was one of the most impactful experiences uh, that we had, being able to talk to another parent. Um, so, and we recognize, we've seen, I mean, I know COVID had a hard impact, kind of wiped out volunteerism in hospitals everywhere for a period of time, and many have struggled to kind of come back from that. Um, Part of the reason why all of our mentors have always been virtual, because we want to be, and many of them, the parents just want to text or maybe talk every once in a while, but a lot of it's just kind of messaging these days. And being available anytime, anywhere, being able to connect with a parent that's has gone through something similar to what you're dealing with, so you can kind of again
Mhm.
speak the same, talking about kind of the same things. Um, I think what we found too, also sometimes actually, the fact that the mentor is not at the same facility can help, because the parent's not worried about just people knowing people, and um, being worried about if it'll impact like the care maybe somehow, some way that they're going
Mhm.
to receive. So a little bit of that, the kind of that physical distance, um, seems to uh, seems to help. And so we're trying to add, more languages. We have quite a few that we cover a pretty broad spectrum of experiences, and we just do one-on-one matches. So I often share, I'm like, we have support across, for different types. Some people like data, some people like the feelings. Everybody finds support. Some people like to write. Everybody finds support in different ways. Um, but I do feel like having someone else to talk to, regardless of what you're going through in life. Um, this happens to be one of those experiences that most parents report as being fairly overwhelming. And so, a fairly overwhelming experience, having someone to talk to usually can make a difference. Is usually really helpful. Have you continued to been able to continue to maintain? Sounds like you have the mentor program that you have at your.
It's not the same as it was at that time. It's it's waxed and waned over the years. We now have a full-time parent coordinator paid position, which is good. We took quite a few years to get that going, but I think our family support is pretty good. I mean, we've there've been a lot of different aspects that have been added over the years, but I think the early days were probably as good as what we have now.
Well, it reminds it's a reminder to me actually. I mean, you're at a location that has some of the best outcomes, which means that your parents, if the baby's born there, they're actually likely to be there for a couple of months.
Yeah,
Like that's why I always say, it's like it's a place where, in some respects, you hope for a long stay. Because if it's a
yeah,
short stay, it means your baby didn't survive, right? And so if it's a long stay, it's there you're more likely going to require or benefit from some type of support some point along your journey. Um, so to some extent, knowing that even your program has waxed and waned, is a reminder to me of just how important it is that we really take a community approach, um, to this to our work. The parents matter, the support matters, obviously your staff, the doctors, the nurses, and their mindset, the approach, and what a difference that makes in in the outcomes.
yeah.
Before we wrap up, I guess I'd like to end by saying, is there any question that I haven't asked that would have given you the opportunity to share anything that you would have liked to that you didn't get a chance to share already?
No, I think the fact that you have been in the situation of being a NICU parent gives us a special perspective in this conversation that's very important. When as I've dealt with families over the years, I think the most important thing that I try to keep in mind is to put myself in their place and say, how would I like to be treated, and how would I like to be communicated with? And I think that serves us best as physicians and nurses is to just try to do it that way. And I think that's worked well. I mean, when I first began to confront the needs of families as a young medical director, it was the mother of twins who herself was a nurse who said to me, "Why can't we be in the unit? These are our babies." She was not happy to be escorted out when rounds started. She was very direct, and that I appreciated that, and started working from that perspective. But I think I think that's been my guiding principles, to just try to listen to parents and see things from their perspective. And it's been helpful both in my role as a care provider, but also as a researcher. I think when we look at what outcomes we should measure for these babies, uh, we're learning that the things we have traditionally looked at are not necessarily the things that parents and patients find most important. We've been looking at various Bailey scores and crazy definitions, composite outcomes of death or neurodevelopmental impairment, whereas parents and patients are more interested in things like, uh, is my child happy? Uh, can can she attend school? Does she have friends? Is he going to be able to support himself someday and live independently? Things like that.
Yeah, I remember I shared a piece I wrote for Father's Day, probably at least 10 years ago or longer. I said, one of the blessings of having a baby born early and that you're hoping you get to bring home is that typically parents have this expectation that their child is going to, um, boy, I hope they're good in sports like me, or I hope they're great at math like I am, or sort of um, seeing some part of themselves in their children. When your baby is born early and you know that they've come through a lot to be able to be alive and be able to bring them home. Really, that's what those are the things that you're hoping for. It really is those. It's the simple things, and yet um, that's really what I think we want for everyone. So there's no expectations. You sort of drop the expectations, and you're just,
It helps you focus on what's really important.
yeah, yeah, that's right. Well, Ed, I really appreciate your time today. Obviously, we in the Preemie parent community appreciate all the work and the contributions you have made to neonatology, to the outcomes. Yeah, it makes a real difference. So we appreciate it.
Thanks for having me.